Hello, I'm Andrew Wong. I'm at Duke University Medical Center in North Carolina, and I'm very pleased today to have you join me in discussing the results of this important study, LIVE-HCM study, with the principal investigator, Dr. Rachel Lampert, who's a professor of medicine at Yale University. So thank you so much, Rachel, for joining us on this.
Andrew, it's such a pleasure to be here speaking with you and the HCM Society.
Next slide, please. So this is a new endeavor, our webcast from the HCM Society, and the title of it appropriately is called In the Thick of It. And our goals are to broadly communicate new information about hypertrophic cardiomyopathy to improve the understanding of the disease and the treatment of patients living with hypertrophic cardiomyopathy. We also want to engage with diverse professionals in the field of hypertrophic cardiomyopathy, really to promote ongoing and future collaborations in hypertrophic cardiomyopathy-related research, education, and clinical care. So we'll start with this very important study. These are our disclosures. Next slide. So Dr. Lampert, can you tell us what led you to design and do this important study?
Well, thank you, Andrew. So the benefits of exercise, physical and psychological, are well known to us for decades. However, due to concern for risk of ventricular arrhythmias and sudden death, for many populations with cardiac disease, specifically patients with hypertrophic cardiomyopathy, exercise has been restricted for many decades. However, prospective comparative data on the safety of vigorous exercise for these individuals has been lacking. So we set out on the LIVE-HCM, or Lifestyle and Exercise in HCM study, to determine whether engagement in vigorous exercise, including competitive sports, is associated with an increased risk for life-threatening ventricular arrhythmias or mortality in individuals with HCM who were followed prospectively for 3 years. So our inclusion criteria included individuals with a diagnosis of HCM or those who were genotype positive without LVH, i.e. phenotype negative. We had some exclusion criteria, specifically conditions which precluded exercise, whether class 3 or 4 heart failure due to the HCM or other types of conditions such as musculoskeletal issues. We excluded those with syndromic types of infiltrative disease that were not straightforward sarcomeric HCM. And we were not able to include those who could not complete the questionnaires online, such as those with language or cognitive barriers. We had 2 avenues of recruitment. One was typical site recruitment. We had 42 sites in the US, UK, Canada, Australia, and New Zealand. And we also had patients who self-enrolled. So we disseminated information through patient advocacy organizations, including the HCMA, SADS, and also through notification of physicians. And patients who heard about us and wanted to participate could contact the central site, Yale, directly. For those patients, we confirmed their diagnosis and eligibility through chart review. And we obtained their echocardiogram data on disk and had it read at a core lab at Mayo Clinic to confirm the diagnosis. We were enrolling patients between May 2015 and February 2019. So when they were first enrolled, the first thing we asked them to do was fill out some online questionnaires to get a sense of what they were doing. This was an observational study. We were enrolling patients across the spectrum of exercise, from the sedentary to the moderate to the vigorous. And so the first thing we asked them to do was to fill out an online questionnaire based on the Minnesota Leisure Time Activity Questionnaire about what they were doing, how many hours per week, how many weeks per year, how many years they'd been doing it. And we then classified them based on that information into sedentary, moderate, and vigorous using standard definitions. We obtained clinical data from the sites or from primary cardiologists, and we then followed them over every 6 months with a questionnaire that asked them, have you had any of the following endpoints? Have you had a cardiac arrest? Have you passed out? Have you had an appropriate shock from your defibrillator, if you have one? And then we also ascertained deaths.
Dr. Lampert, did patients require clearance from their physicians to participate in this? And were there any special tests that were needed to be done to risk stratify patients before they could enroll?
So patients could enroll either through a site, so then their physician, asked them to enroll, but also if they wanted to self-enroll, they didn't need to go through their physician. For all patients, we acquired information about their clinical risk profile through their records. We did ascertain or confirm the diagnosis through an echo reading for those who were self-enrolled, but all the assessments we abstracted from their clinical records.
And did patients have to update their exercise classification throughout the study to show that they were continuing to exercise at that level?
We did ask them to fill out, has your exercise pattern changed? But the analysis is based on just their baseline classification. So we classified them once, and from there, we put them into groups that way.
Great, thank you.
So here's who enrolled. Basically, we had 699 vigorous patients and 961 who fell into either the sedentary or moderate groups. We had originally planned actually to group the moderate and vigorous, but luckily we had quite a few vigorous patients enroll. So we were able to really pull them out to answer the question we cared most about, which is the safety of vigorous exercise. So we compared the vigorous exercisers to the non-vigorous, and then we also broke down the vigorous into competitive and non-competitive. So this shows who was participating. Overall, about 20% were under 25, about 70% were over 25, 2/3 male. Here's the racial breakdown. We had about 40-some% who were genotype positive, and then some that were negative, and many that had not yet been tested. And we did, as I mentioned at the beginning, we did enroll some phenotype negative patients, but there were not a lot of those. There were overall 8% in the group as a whole. So here's more information about the group. So here, apical morphology, slightly more in the vigorous group. Cardiac arrest was actually more in the vigorous. Maximal wall thickness did differ statistically, although numerically it really wasn't very different. 20 millimeters in the vigorous versus 21 in the non-vigorous. As far as known risk factors for our arrhythmic endpoint, the only two that actually differed between the groups was this very small difference in maximal wall thickness and history of cardiac arrest.
So it's interesting to me that that number one, a fairly high percentage had a primary prevention ICD, which defines a higher risk group of patients before we get to the results, and also that a fairly high percent were not only participating in vigorous exercise, but competitive vigorous exercise.
Yeah, that's true. So we did have a fair number of ICD patients, more, I think, than the general population of HCM patients in the community. It was about 40%. It did not differ between the groups, so it didn't bias the results in any way. But it is a high number here. And I think whether that's because based on prior data, more individuals with ICDs are choosing to be vigorous, and those are, tended to be over represented in the study, or whether that's related to kind of who tended to enroll patients, we don't really know. But it was balanced though between the two groups. Yes, and then we did have a fair number that described themselves as competitive as well.
Yeah.
I'll give you a little more information about the competitives. I didn't put it on a slide, but this is really everyone that self-described themselves as competitive. We did ask patients to describe what level they were competing. So were they playing in a league, just on competing on their own, like in a marathon? Were they actually on a team, and what level they were competing at? So I didn't pull out the data on a separate slide, but we did have 56 young people. So we did look at the group that would be the most highly competitive, like interscholastic athletes. So between age 14 and 22, we did have 56 athletes competing at a varsity or traveling team, high level competition between age 14 and 22. of whom 42 of the 56 were phenotype positive. So we had a fair number of highly competitive young people, and we did compare them as well. We did pull them out as well and compare them to the similarly aged individuals who were not athletes.
Yeah, and one thing, as you pointed out, over 40% of patients in both groups had a provocable outflow tract obstruction as well. So a group of patients that we might consider higher risk for events such as syncope during exercise, but 40% had a provocable gradient. This is a really interesting patient cohort.
Yeah, so I would not say it was a low risk cohort.
I agree.
Yeah. I mean, I think mostly most of the patients that were higher risk, I think, did have defibrillators, but it was not a low risk group.
Right.
Okay. All right. So here's our results. So as far as our total composite endpoint, basically overall we had 15.6 events, which I'm sorry, we had 77 events, which corresponds to 15.6 per 1,000 patient years. And these really differed not at all between the non-vigorous at 15.3 per 1,000 patient years and 15.9 for the vigorous. And as you can see here in the Kaplan-Meier curve, looking at the probability of freedom from the composite endpoint, basically the two lines are pretty much superimposed. So this takes us to the hazard ratios as a way of really defining the comparison. So in our primary analysis, which looked at all of the patients, just comparing vigorous to non-vigorous, the hazard ratio for any of the composite endpoints was 1.01. Now, we had set this up as a non-inferiority analysis, hypothesizing that the vigorous exercise would not be inferior to non-vigorous exercise with an inferiority boundary of 1.5, and we did meet that boundary. So we were able to stay with statistical confidence that the vigorous exercise was not higher risk than non-vigorous exercise. We did some secondary analyses as well. We looked at the pairwise comparisons between the different groups. You see some different point estimates, but basically they're all pretty much clustered around 1. We also, to look at the competitive athletes, we took out the vigorous non-competitive and compared the competitive to everyone else. And again, did not find a difference in the main results. We also took out the phenotype negative individuals. We thought it was important to include them. We can talk about why a little later, but we did include them, but we also wanted to see what the data looked like without them. And so here we see the hazard ratio again is almost identical, 1.06 without the phenotype negatives. And then when we looked at we took out the symptomatic patients and again found really similar hazard ratios throughout. One of the things that's important to think about too is that this was set up as a non-inferiority, but there was no superiority found for either non-vigorous or vigorous exercise in any subgroup.
Very consistent findings across all of your subgroup comparisons, which certainly reassuring as we try to think about generalizing some of these findings. Yeah.
And something that will be coming out as well in the that we presented at the time of the abstract as well. Among the 42 phenotype positive, really high-level athletes, there was one event which was less than the number of events in the moderate and sedentary in that same age group. So we didn't have enough of those young people to talk about statistics, but we were also able to say very low incidence rate in that group. So in conclusion, in this prospective study of 1,660 individuals with HCM or genotype positive, phenotype negative, which was 8%, those engaged in vigorous exercise did not experience a heightened risk of death, cardiac arrest, appropriate ICD shock, or arrhythmic syncope compared to individuals engaging in low to moderate intensity physical activity. Individuals who were participating in high intensity sports, also we did not see a heightened risk. The overall event rates were low, with less than 5% experiencing the composite endpoint over 3 years. Post hoc analysis limited only to those with overt HCM showed similar hazard ratios, and in neither the primary patient population or any subgroup was either vigorous or non-vigorous shown to be safer. So, I think really the take-home message from these data will inform discussions between patients and physicians regarding vigorous exercise in the context of expert assessment and management of HCM using an individualized shared decision-making framework. And these data do not support universal restriction of vigorous exercise in patients with HCM.
That's an amazing study and really important, I think, as we think about counseling patients with regard to exercise. Were there any, aside from some of the characteristics of the patients, were there any surprising findings that were unexpected to you that you thought, I was not anticipating that?
Not so far. I think our primary findings were pretty much what we had hypothesized. We went into the study with, as I said, a non-inferiority hypothesis, and so I think we were pleased to see that did play out. I think one point I just would want to emphasize again is this concept of expert assessment and management of HCM. The vast majority of our patients either were enrolled by a high volume center or had been seen in one. And so, I think that we can feel confident that they had been appropriately risk assessed. If they needed a defibrillator, they had gotten one. And so I think it's really in that context that we should be talking about exercise with our patients. It really should be HCM experts having that conversation.
Are there any plans to follow any of these participants longer term to see?
Yeah, we're hoping to do that. We are hoping to have a IRB approval for a long-term follow-up, and we'll be hoping that we get funding for that as well.
Yeah, I think these results will be very useful to all of us who take care of patients with hypertrophic cardiomyopathy. From the extreme of some patients coming in saying they've been told that they shouldn't walk up a flight of stairs, this is really at the other leading edge to say, well, you can actually not only do moderate level of physical exercise, but in the right context for the right patient, it may be safe to participate in even vigorous. And as you said, the most important thing is the careful risk assessment and the shared decision-making. But I think your results show that there are many patients with hypertrophic cardiomyopathy who are very interested in doing vigorous exercise and are doing it on their own, and having data to support the safety in the right context is so important.
And I think when you bring up about the restriction and whether they were doing it on their own, we did ask the question as part of our online, baseline surveys, what does your doctor tell you about exercise? And overall, both the vigorous and the non-vigorous groups, 80% told us that at least one doctor had told them that they should not be exercising vigorously. So they were doing it anyway. But I think, with these data, hopefully two patients will talk more openly with their physicians. Physicians will feel more comfortable talking to their patients. So we won't have patients, running around behind their doctor's back.
Feeling guilty about it, right?
Right. I think it will help with that open communication.
This has been fantastic. I've learned a lot. Thank you so much, Dr. Lampert, for sharing these results with us and spending time with us. And I think this is really going to help not only providers, but patients with hypertrophic cardiomyopathy. So thank you again.
Well, thank you. Thanks so much for your interest in the study and inviting me to speak with you today.